Hi, welcome to Medicoria. In today's video we shall be discussing the pathology of atherosclerosis. I'll be discussing this using illustrations I created to make things simple but without losing the valuable information. The word atherosclerosis originates from two Greek words. The athero part of the word means a wax or gruel, which simply refers to the necrotic core of the atherosclerotic plaque, as we shall be illustrating shortly. The sclerosis part of the word refers to induration or hardening, which corresponds to the fibrous part of the atherosclerotic plaque. Atherosclerosis occurs in the large and medium-sized muscular and elastic arteries. It results in blockage of blood flow to the different organs, resulting in ischemia of the heart, the brain, the kidneys, the limbs, and it can also lead to aneurysms in the blood vessels. Atherosclerosis occurs in those regions of the blood vessels where they branch or where there is marked curvature and where blood undergoes sudden changes in velocity and in direction of flow. The etiology of atherosclerosis is not known. However, genetic and acquired factors have been identified to be involved in the disease. You can interest yourself in finding out which genes particularly are involved in the process of atherosclerosis. For example, the apolipoprotein E gene. Atherosclerosis involves different processes. For example, endothelial dysfunction, inflammation, smooth muscle cell proliferation, lipid metabolism, intimal injury, and coagulation. This image summarizes the process of the development of the atherosclerotic plaque, beginning with the normal vessel on the left-hand side and going all the way to the advanced or vulnerable plaque on the right hand side of the vessel. I'll be taking you into the detailed events that take place at every stage of the development of the atherosclerotic plaque. During my discussion, I'll also be breaking down the American Heart Association classification of atherosclerotic lesions based on a consensus. I'll be highlighting both the older classification and the modified classification. Let's open the discussion with a review of the normal anatomy of an artery. The wall of an artery has three main layers: the tunica intima, tunica media, and tunica externa, also known as tunica adventitia. The tunica intima further has three components: the endothelium, which forms the inner lining of the blood vessel, the subendothelium, and the internal elastic lamina, which I have illustrated here in blue. The tunica media, on the other hand, is rich in smooth muscle cells and is bounded by the external elastic lamina, which I have also illustrated here in blue. Here I'm going to zoom into the tunica intima, which is going to be our main focus in this video, because atherosclerosis mainly involves the tunica intima and rarely involves the other layers of the arterial wall. Here in our zoomed out view, we can clearly appreciate the flattened squamous cells of the endothelium. In the subendothelium, we have a very small number of smooth muscle cells and also connective tissues, mainly collagen and elastin. And here in blue again is our internal elastic lamina. So let's zoom in even more to look at the events that take place during the development of the atherosclerotic plaque. Like already mentioned, atherosclerosis tends to develop in those points where arteries branch or where there is curvature, and in those points where there is sudden change in the direction or the velocity of blood flow. In other words, we're talking about those points where there is turbulence of flow. This turbulence of blood flow results in fluid shear stress that leads to endothelial dysfunction. The dysfunction is mediated through a type of proteins known as the flow-sensitive proteins. One of the dimensions of endothelial dysfunction is increased expression of molecules known as adhesins and integrins. These molecules increase the binding and adherence of the circulating monocytes to the endothelium. Once bound to the endothelium, the monocytes find their way into the subendothelial space by a process known as diapedisis, and once here, they form the macrophages. The macrophages, together with the dysfunctional endothelium, release a variety of growth factors which stimulate division of the smooth muscle cells by mitosis. This leads to proliferation of these cells and thickening of the tunica intima. The lesion at this stage is known as a type 1 atherosclerotic lesion, also known as adaptive intimal thickening. Autopsy studies performed on fetuses have shown that this process happens in utero. In other words, a fetus with genes for atherosclerosis is born with an already thickened tunica intima. The following stages of atherosclerotic plaque development take a decade or more to develop, and the rate of progression of the lesions can be modified by environmental factors such as diet. The other dimension of the endothelial dysfunction is increased permeability of the endothelium to lipoproteins, particularly the low-density lipoproteins. These find their way into the subendothelial space through an abnormal pathway. Once in the subendothelial space, the LDL are oxidized to oxidized LDL. This process of oxidation is carried out by enzymes that are released by the macrophages, for example lipooxygenases, myeloperoxidases, inducible nitric oxide synthase, NADPH oxidase. From this point, it is therefore apparent that the level of oxidative stress in an individual has an important influence on the rate of progression of the lesions. Likewise, the concentration of LDL in the individual's blood also influences the rate of progression of the lesion. The macrophages soon start to engulf and phagocytose the oxidized lipoproteins. As the macrophages become laden with these lipoproteins, they form what is known as the foam cells. They are called so owing to their appearance under the light microscope. Aggregates of foam cells are also visible to the naked eye without magnification, in which case they appear as yellow streaks. Therefore, lesions at this stage are known as fatty streaks, or type 2 lesions of atherosclerosis. In the modified classification, they are referred to as intimoxanthoma. Type 1 and type 2 lesions are known as non-progressive atherosclerotic lesions. As a matter of fact, type 2 lesions can actually regress. The foam cells are not able to effectively break down the oxidized lipoprotein particles. As a result, they undergo apoptosis, releasing free cholesterol from the incompletely broken down lipoproteins, as well as some free cholesterol from the content of their own cell membranes. This results in the formation of multiple small focal deposits of extracellular lipid. At this stage, we also observe infiltrates by lymphocytes joining in the process. At the same time, there is continued proliferation of the smooth muscle cells, as well as deposition of connective tissue in the form of collagen and deposition of proteoglycan matrix. Lesions at this stage are known as type 3 atherosclerotic lesions, also known as intermediate lesions or transitional lesions. In the newer classification, it is known as pathologic intimo thickening. From this stage onwards, the atherosclerotic lesions are known as progressive atherosclerotic lesions. This is due to the fact that they cannot regress from this point onwards. The multiple small focal extracellular lipid deposits merge together to form a larger deposit of lipids known as an atheroma. This is a type 4 atherosclerotic lesion. It is important to note that at this stage, there is no fibrous cap covering this lesion. Lesions from this stage onwards are known as advanced atherosclerotic lesions. This is because from this stage onwards, these lesions can become complicated plaques, as we shall see later on. The next stage of atherosclerosis are the type 5 lesions, also known as the fibroatheroma. In this stage, there is now a fibrous cap covering the lipid deposit. This fibrous cap is composed mainly of collagen, but it also contains a few smooth muscle cells, proteoglycans, and inflammatory cells. In this lesion, I would like us to note these tiny blood vessels I've tried to illustrate here, known as vasa vasorum. These lesions develop their own microvasculature, supplying them with blood. And as we shall learn later on, this is going to be the source of hemorrhage into the plaque. The other important component of this fibroatheroma is the necrotic core that we talked about earlier. The necrotic core mainly contains free cholesterol and cellular debris from the death of cells resulting from inflammation, as well as apoptosis of the macrophages themselves. This process keeps getting worse because the macrophages in this process have a defective phagocytosis. In the previous image, we noted a thick fibrous cap covering the lipid deposits. However, as this necrotic core continues to grow over time, there is thinning of the fibrous cap. This is mainly a result of breakdown of the connective tissue in here by matrix metalloproteases produced mainly by the macrophages. The thinning of the fibrous cap, together with the growth of the necrotic core in here, make this plaque vulnerable to rupture. At this point, I would also like us to note deposits of calcium that might form within this plaque. This calcium most likely originates from the dead smooth muscle cells. Remember, smooth muscle cells always contain a reservoir of calcium inside them to facilitate the process of contraction. So all these factors together make this plaque vulnerable, as we shall explain shortly. The next stage of atherosclerosis is the type 6 lesions, also known as complicated plaques in the older classification. This involves those plaques where there is a hemorrhage or a hematoma, those plaques with surface defects, or those plaques complicated by thrombosis. In the newer classification, these complicated plaques have been designated names basing on their specific features as follows. Here is a plaque with a hemorrhage or a hematoma forming within it. This hematoma is usually a result of bleeding from the vasa vasorum that have newly formed. I already hinted on the concept of vulnerability of the plaque as a result of thinning of the fibrous cap and as a result of the growth of the necrotic core causing expansion of the plaque. The third factor leading to increased vulnerability of the plaque is the hematoma, which also causes this plaque to expand outwards. The second type of complicated plaque that we are going to look at is a ruptured plaque. A ruptured plaque is one in which there is disruption of the fibrous cap and the endothelium, leading to exposure of thrombogenic material beneath. This results in formation of a clot or a thrombus that could potentially block a blood vessel. Plaque rupture is the most common cause of thrombotic events in atherosclerosis. The second most common cause of thrombotic events is a phenomenon known as plaque erosion. Plaque erosion refers to disruption of the endothelium but without disruption of the fibrous cap. All the same, there is exposure of thrombogenic material underneath. However, the difference here is that the thrombus which is formed does not communicate with the necrotic core of the plaque. The last type of complicated plaque that I would like us to look at is the eruptive plaque, in which there is shedding of the calcified nodules. I already hinted on the calcified nodules earlier on. So this can erupt and also expose thrombogenic material underneath. This also results in formation of a thrombus, which does not communicate with the necrotic core of the plaque. Complicated plaques do not form the last stage of atherosclerosis. There is still more to atherosclerosis than this, and we shall be covering this in a moment. If you're already enjoying the video, don't forget to like it and to hit the subscribe button. So in the event that we have atherosclerotic lesions with acute thrombi and the patient lives to see another day, there is a healing process that takes place. This basically involves replacement of the thrombus with connective tissue and covering that connective tissue with a layer of endothelium. There may or may not be further calcification. Studies have actually shown that repeated thrombosis and healing of the thrombi is a major contributor to the growth of the plaque. But it appears that these subclinical thrombotic events involve formation of small thrombi that later on heal. Lastly, I would like to talk about how the vessels remodel themselves during the process of atherosclerosis. There are two types of vascular remodeling that take place. One is negative remodeling, in which the atherosclerotic plaque grows inwards into the lumen of the artery, narrowing it. These plaques are more prone to rupture and thrombotic events. The second type of remodeling is positive remodeling, in which the plaque results in outward growth of the arterial wall. In this type of remodeling, there is a slower narrowing of the lumen of the artery. These plaques have a tendency to result in weakening of the arterial wall and formation of aneurysms. That is it for today's video. Thank you for watching till the end. Don't forget to like, to comment, to subscribe to the channel, and to turn on your notifications. Also, feel free to leave a donation behind via the means I have outlined in the description box of this video. Thank you and see you next time.